Hello, and welcome to the Pediatric Brain Tumor Foundation's webinar, Hope and Healing, Advancements in Pediatric Neurosurgery for Brain Tumors. My name is Alex Henderson, and I'm the Bilingual Family Support Manager for the Pediatric Brain Tumor Foundation. Thank you for joining us today for this important subject. Before we get started, I have a few guidelines to review. You are muted for this webinar, and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We might not get to every question, but we'll try to answer as many as possible. And we are pleased to welcome Dr. George Jallo for today's webinar. Dr. George Jallo is a professor of neurosurgery, pediatrics, and oncology at Johns Hopkins University School of Medicine, where he joined the staff in September of 2015. He also works at Johns Hopkins All Children's Hospital as a director. He was previously the director of pediatric neurosurgery at Johns Hopkins Hospital. In addition to leading a neuroscience team ranked by U.S. News & World Report, he is the physician-in-chief at Johns Hopkins All Children's Hospital and vice dean since 2019. His areas of expertise include tumors of the brain and spinal cord, intraoperative neurophysiological monitoring for eloquent tumors, use of minimally invasive technologies such as endoscopy and keyhole surgery. And he has published more than 300 peer-reviewed scientific articles, 100 book chapters, and is co-editor of 6 textbooks on pediatric neurosurgery, pediatric epilepsy surgery, and hydrocephalus. His laboratory was one of the first in the world to create the models for both brainstem and spinal cord tumors in small animals, and he was able to also safely locally deliver chemotherapy agents and radiosensitizers to improve survival. Dr. Jallo earned his medical degree at the University of Virginia Medical School and completed his residency in neurosurgery at New York University Medical Center and fellowship in pediatric neurosurgery at Beth Israel Medical Center Institute for Neurology and Neurosurgery prior to joining Johns Hopkins University in 2003. So it gives me great pleasure to introduce Dr. George Jallo.
Thank you, Alex, and good morning, good afternoon, everybody. Just want to thank Alex as well as you all for participating in this webinar today. And I'll try to just highlight some of the advances in pediatric brain tumor surgery that we've seen, the evolution both in neurosurgery, neurological care, as well as neuro-oncology. For disclosures, I really have none, aside for some simple brain tumor facts, in the sense that there's close to 3/4 of a billion people that may be living in the United States with a primary brain or central nervous system tumors, and that brain tumors are the most common form of cancer in children between the ages from birth and 14, and that there are over 100 types of brain tumors, both in children and adults. When we look at children, I think what we recognize, I think just some facts, is that several years ago in 2023, there's an estimated about 4,000 brain tumors in children less than 21 years of age, and that 1 in almost 300 children will be diagnosed with the cancer before the age of 20. And that translates to about somewhere between 10 to 15 new cases each day in the United States. And unfortunately, I think, when we look at pediatric brain tumors or cancers, really, it has, one of the lowest potential for cure than any other cancer or disease. I mean, when we look in the news each day and every day, we read about gene therapy for some of the neuromuscular disorders, gene therapy cures for sickle cell, thalassemias, and or other types of hematological disorders. Whereas I think we really haven't seen the advances in brain tumors, and in particular pediatric brain tumors. And as I said, I started that, if you look at this slide, and I know sometimes it's hard to read, the red is brain tumors, and this is from the national report looking at brain tumors in diagnosed in the United States from 2017 to 2021. It's the most recent data that's available, and you can see that really whether from from birth to 19 years of age or less than 20, that the brain tumors in red are probably the most common. The only exception, I think, is you can see that the blood-borne disorders in children 1 to 4 is slightly more common. But when you add up from 0 to less than 20, it is brain tumors. And when you look at the types of brain tumors, you can see that they're all over. And this is in both children and adults, but whereas this is in children, and you can see that really the tumors that are in the suprasellar region account for about 20%. Brainstem tumors are 10%, and then the other parts of the brain are all less than 10%, except for the posterior fossa. Tumors in children, I look at it that they can be supratentorial, infratentorial. Supratentorial is that's the brain that's above the brainstem and the cerebellum. Infratentorial is that part of the brain below the tent, or we define that as the brainstem and cerebellar tumors. And you can see that in newborns, you're more likely to have supratentorial tumors, and then from age 1 to about 12. That's where the infratentorial or posterior fossa tumors, brainstem tumors, cerebellar tumors are more common than tumors in the supratentorial space. And about age 12, they cross over again. And you can see the types of tumors that can be afflicted by those ages along the spectrum, such as ependymomas, grade 1 astrocytomas, and medulloblastomas. So what are the advances? And let's get to this. I think the first advance is really there's been significant advances in neuro-oncology, whereas before we used to just get a piece of the tumor, whether it was a biopsy or a resection removal, and then our pathologists would look at it, they would stain it, the histology, and then they would define and give that tumor a name. I think now the new era is really molecular biology and the genetics of these tumors. And really, this was just several years ago, the new classification, the WHO classification, which really defines all brain tumors, brain and spinal cord tumors, both in children and adults. And you can see the original classification started in 2007. We've had several updates to it, and we're at the 5th edition in 2021. And now, we've recognized new tumor types, and you can see all the different new names of tumors. What we used to consider ependymomas, as an example, an ependymoma in the cerebellum, an ependymoma in the spinal cord, or an ependymoma in the supratentorial space was all classified as one. But I can tell you, when 20 years ago when I was in training, surgeons recognized that an ependymoma of the spinal cord, although histologically looked the same under the microscope for the pathologists, it behaved very differently than an ependymoma in the posterior fossa. So clearly, I think what we've developed now is an integrated diagnosis. It's the histology gives you the diagnosis of the name of it. Then you add the grade, whether it's a hot, malignant grade 4 for this glioblastoma, and then you add the molecular information to see what are the gene mutations. And this then allows that patient with that diagnosis to be eligible for the best protocol that may be currently available in the United States or elsewhere. So, again, I did mention this briefly. Ependymoma when I was in training in the early 2000s, an ependymoma was an ependymoma. It was not, yes, it was in the supratentorial space or the posterior fossa or in the spinal cord. But if I gave a small piece of that tumor to a pathologist, they didn't see any of the surrounding brain or spinal cord, they could not tell where it was coming from. And they would just classify it as an ependymoma. And the treatment, what we felt was for all ependymomas, was that really the treatment and the outcome is very different based on the location. and that these tumors are very different. You can see now, we've got two different types of supratentorial ependymomas that have mutations associated with them, and that afflict, different age groups of children, young versus older children and adolescents. The posterior fossa tumors, again, now there's also two types, a group A and a group B, and one's got a little more aggressive behavior, although histologically it looks identical to the group B variant, which is more in older children and adolescents. And then your spinal ependymoma, which tend to be more in old, I'd say college age students and adults rather than in the younger children. So these, clearly we're understanding more and more about these ependymomas, and as I shared, that that the group A's are a little more aggressive and have a worse prognosis of group B. And really, the goal of treatment is a gross total resection, trying to remove as much of the tumor as safely as possible. And that, in these cases, for group A especially, if on the postoperative MRI, there's residual disease, the surgeons or the treating team will consider a second look operation to achieve a gross total surgery if it's safely possible. Again, safely possible if it's not stuck to the brainstem or not stuck to some of the cranial nerves. One should advocate for this. The group Bs, which is in older adolescents and young adults, tends to have a much better prognosis. And there too, you really, if one is able to achieve gross total resection, one may consider, what do we do for treatment? Radiation therapy and or a trial of observation. And then if we look at the supratentorial, we do know that the YAP1 fusion mutation really it tends to have a better prognosis. And what we do know is that a gross total resection, again, if it requires more than one resection, is the best treatment at the present time. And then, the question of radiation therapy is controversial for these. And that's the same thing for spinal cord tumors. If one is able to achieve a gross total resection of a spinal cord ependymoma, really don't advocate for radiation therapy. So I think what we really want to just base it on multiple studies, and really St. Jude's was the biggest advocate of a radical or gross total resection, even if it took several operations, in knowing that the oral aggression free or the overall survival is better for these tumors, and the same is true for the spinal cord ependymomas. And I think the same advocate for proton beam radiation for those posterior fossa tumors that are ependymomas. Now let's talk about medulloblastomas. I think we've come a long way. I think from the first description was in the 1920s when neurosurgery, when the first neurosurgeon in the United States advocated for the special field of neurosurgery. We've come from, the diagnosis has been different. The radiation was introduced, and for decades we considered them as one tumor, a medulloblastoma. And there were some variants in terms of whether it's an anaplastic, a little more aggressive, a little more rapidly divided. But I think really in I'd say it's what we found was, in the early 2000s, that really we advocated that there are multiple molecular subgroups of medulloblastoma. And it was the first time that, that we subdivided them into different types based on the molecular understanding of these. And some groups have advocated that there's more than 4. There might be almost a dozen subtypes. And I think, early on in the early 1990s, there too, similar to ependymomas, we really looked, they looked at the age that children less than 3 tend to have a worse prognosis than older children. And then they didn't advocate for a gross total resection in the early COG studies. the children's oncology group, they advocate that if you could achieve a near total resection and leave less than 1.5 centimeters squared in an area of that, that those children had a better prognosis as compared to children that had more residual disease. And there too, there's advocation early on for second look or second repeat operations to achieve that, to provide that child with the best. Now, what we do know is there's 4 types. There's the Wnt group, the sonic hedgehog, the group 3, and the group 4. And you can see that the location's different, and that some tend to be better overall prognosis as compared to the group 3s, which is probably one of the most aggressive. You can see the mutations and the genes that are associated with them, and then the age being seen more in the younger children with the sonic hedgehog and the group 3 as compared to the older children. And what we do know is that some of these are much more likely to disseminate. And I think, as I mentioned, with the new changes now, knowing that there's the subtypes, the ones that are have a very good prognosis, one may consider leaving that a little more residual than what we had originally considered in the 1990s. And you can see it here based on the types, the molecular subgroups here, the Wnt group, the sonic hedgehog, or the group 3, or the group 4, and their the overall prognosis and the risks for stratification. And this is a much more a detailed treatment algorithm that we would use once we have all the information. Now, what does it mean? What this translates to is really, when we talk about medullos, is it's not just the pathologist looking at the slides and giving up the histological diagnosis that's a medullo. A lot of times this adds, anywhere from a week to 2 weeks to get the molecular signature of that, to better define the tumor, whether it's, in which of these 4 categories does it belong. All right, I will switch gears now to brainstem tumors, and I think probably one of the most eloquent areas and most difficult tumors to operate over. But what you have to recognize is that not all brainstem tumors are alike. Yes, it's called a brainstem tumor, but depending upon the region in the brainstem, whether it's in the midbrain, the pons, or the medulla, really determine whether the histology of the tumor, the aggressiveness of the tumor, as well as the surgical options, and really the overall prognosis for this. I think the prototypical brainstem tumor is that diffuse midline glioma that we now call, or what used to be called that diffuse pontine glioma. This is an infiltrative tumor that involves the pons, and this is the pons. That's the part of the brainstem there that's responsible for a lot of cranial nerves that are responsible for moving your eyes, swallowing, smiling, and even the motor pathways go through there. And you can see how wide this pons is in this tumor, and these are non-operative. One cannot go in there and resect these tumors safely because they're infiltrative. They spread their tentacles inside the brainstem, which makes them inoperable in a sense because of their diffuse nature. Whereas here's another tumor in the pons, and you can see that this is a grade 1. This is a pilocytic tumor with a small tumor nodule and a cyst. And as much as I said, that diffuse pontine tumors are inoperable, this tumor is operable, although it's in the same location. And the reason for this is that this is a focal or a well-circumscribed tumor that can be removed. So, I mean, I think we need to just, if you look at that artist's illustration that we had drawn, I think about 10 years ago, that looked at all the tumors in the brainstem. This is the midbrain, this is the pons, this is the medulla. This is A is a tectal tumor, the classic tectal tumor that arises from the tectum of the midbrain. The B is in the anterior part of the midbrain, or the tegmentum, D, C, E are all pontine tumors. E is the diffuse pontine or the diffuse midline glioma. C is a focal tumor in the pons. D is an exophytic tumor, a tumor that starts in the brainstem, whether it's the pons or the medulla, and comes out of the brainstem into the fourth ventricle, which is a fluid space. And then in the medulla, you've got these focal tumors or this cervical medullary tumor that goes from the brainstem into the upper spinal cord. And essentially that's what all these classification schemes that we use really define, the location in the brainstem and whether it's a focal tumor or a diffuse tumor. And that's what really needs to happen. And as I said, when we look at these tumors in the midbrain, pons, and the medulla, and here's the list of them, it's really whether if it's a focal or a cystic tumor, they tend to be low-grade, indolent, and behaving in a more indolent fashion, whereas your diffuse tumors tend to be infiltrative, a little higher grade histology, and behave very aggressive. And surgery is not safe, cannot safely be performed to achieve a radical or even a gross total resection for these. These tumors in the brainstem, depending upon if they're diffuse or if they're focal, tend to present differently. Focal tumors are slow growing. They're going to present with headaches, vomiting, lethargy, and a long history, a long prodrome of symptoms. And they could be vague, such as failure to thrive, and that they could be worked up for many other things before they're diagnosed with a tumor of the brainstem. Your diffuse pontine tumors, typically the duration of symptoms is shorter because these are very fast-growing tumors, and then they may present with a cranial nerve deficit, whether it's anywhere from the cranial nerve 5 to 12. That could be blurred vision, double vision, a weak smile, swallowing problems, eating difficulty eating, other your tongue not moving and not being able to sticking it straight out and turning towards one side, unsteadiness in gait, and some weakness. And the hydrocephalus is less common with these diffuse tumors as compared to the focal tumors. So what's the management? I think, one, if there's hydrocephalus, and this is really for the focal tumors and in particular the tectogliomas, we would consider a shunt just to see a septoversion, and we wouldn't even biopsy a tectal tumor. It's a radiographic diagnosis. These are very indolent tumors, and I must say, in my career, a classic tectal glioma, I have not really seen grow in the 25 years I've been doing this. If it's a little atypical, yes, it still may be a low-grade tumor, but there might be a slight chance that those may grow. But a classic tectal tumor does not need a biopsy and or treatment for the tumor. It's really just to treat the hydrocephalus. Your diffuse midline tumors, there's no role for surgery, aggressive surgery. The question is whether or not to do a biopsy. I think, many groups have different feelings about it. My personal bias is that if that child is eligible for a trial, a clinical trial that requires tissue, then I do advocate for a stereotactic needle biopsy. But if there are no trials that are open, and there are many trials today that are open for diffuse tumors, if there are no clinical trials, then I would not advocate for a biopsy because honestly, we would be doing it for research and not to the benefit of that child if we're doing the biopsy. And I think that there is some groups that do push for biopsies. The other is diffuse midline tumors that are in the cerebellopeduncle and the thalamus. Some of these can be resected depending upon the location, and it's really adjuvant treatment, radiation / chemotherapy / any open protocol. For the focal tumors, then there's roles of surgery. Some may advocate for a biopsy, others advocate for a radical resection, and really have to weigh the location with the risks and the benefits and the technology that's available. And then today, we've got so many different options for both radiation therapy and chemotherapy. So I think just to summarize, I think, for diffuse midline, there's really no role for surgery for this. And even if the histology looks to be a high grade, a low grade, when you look at the molecular subtype, if there's a H3K27, it's mutation, it's going to really determine the overall prognosis. And you can see that this mutation occurs in 80% of these tumors. You can see the MRI there. And, it depending upon, is it the 3.3 or the 3.1, overall, the ones that do have this mutation, the prognosis tends to be less favorable. And you can see this mutation here and the overall survival, the H3.3 mutation versus the 3.1. So I think really future directions is really looking at new agents, looking at local delivery, interstitial therapy, and then focused therapy. And I will try to get to that. In terms of convection enhanced delivery, my lab looked at this in Baltimore. We worked on small animals, and I think want to commend both the Japanese group here looking at convection enhanced or local delivery of chemotherapy agents into these brainstem tumors. And what they found was, that they did have one response. And again, they don't share the individual cases. They had some 6 partials and some stable disease, 4 progression, 4 progressed. And what they did find was really that it was safe and it can be done. And really in the United States, I think the biggest group that is doing this is Mark Sedane's group at Cornell for diffuse pontine glioma and convection enhanced delivery and showing some promise. And I think there's an open clinical trial there. I think the dreaded, just can't talk enough that, with surgery on the posterior fossa, whether it's a brainstem or a cerebellar tumor, really it's the biggest complication is cerebellar mutism that depending upon the center that you're at, can be reported anywhere up to a third of the patients. And this is really a syndrome that consists of 3 things: some movement difficulties, which is unsteadiness or clumsiness to the point that they may not be able to feed themselves or walk, some language or scanning speech or mutism actually, and then some irritability and apathy in terms of it, and can prolong the recovery as well as the hospital stay. Why does this occur? I think I will say in all my years of doing the surgery, I don't know which child's going to wake up with this. Times when I thought, oh, it was a great surgery. I don't think there was, any complications. That child wakes up with a cerebellar mutism. Other cases where, it was a little more difficult, maybe there's a little more traction, and that child doesn't wake up with posterior fossa syndrome. So I don't think we really know why it occurs. I think, what we do know is to be very efficient, work as quickly, and trying to avoid retraction or stretch on the normal brain or brainstem or the pathways that are there. So I think, looking at this, there are many working groups that are trying to better determine this preoperatively on MRIs to say, okay, this child's going to be at an increased risk. So should we be more careful rather than, be as aggressive? And, when we look at this, these are all the studies, all the papers that are in blue that have looked at this, whether it's involving the brainstem, where it is, the size of it, is that child right-handed, left-handed? Do we do a telar-velar versus incision in the vermis? And what the histology is a medulloblastoma, and really just you can see that some have shown some clinical significance, whereas others haven't. So I think as we move along, I think I might just shift gears a little and just talk about just the operative techniques for some of these. I think traditionally we've done large operations. We've done used fixed retractors. You can see those retractors there, and to get to the tumors to try and resect them. I think for some tumors now, I think we can advocate for a minimally invasive approach where we use a small incision and try to place some small tubular retractors and try to safely remove the tumor with minimizing the risks for retraction and the stretch on the surrounding normal brain. And overall, smaller the incision, The smaller the opening, the smaller the path to get to where you need to get to. It really translates to a less complicated postoperative course. And I think when we talk about minimally invasive neurosurgery, it's been we've advanced the field in craniosynostosis surgery that's looking, children that may have fused sutures. We used to be an open operation. Now we're doing these operations with very small incisions and with an endoscope. The other is approaches. I mean, rather than making the long incision in the hairline, making small incisions for some tumors just above the eyebrow, and making the opening and accessing tumors in the suprasellar or the supratentorial. You can see these tubes are variations of the tube for this to get this, and you can see again just inserting a tube to get to the tumor and then working in this tube to remove it. Here's a tumor, a supratentorial tumor. You can see the opening there. Again, a very small opening that's the size of a $50. You can see the tube that's inserted, and trying to use navigation, the technology that we have to access the tumor. And sometimes we may go in a longer approach to the tumor, knowing that we will avoid some of the pathways or the crossing tracks within the brain to try and preserve the function. And I can tell you, some of the tubes that are available, we've got peel-away catheters that are 8 millimeters. These are where you can insert an endoscope. We have oval-shaped retractors that vary in size from 17 millimeters to 21 millimeters, and circular shaped retractors that are 13.5 millimeters. And to put this in perspective, we're really working through sizes that are somewhere between the size of a dime and a nickel, in the brain tissue itself to access these tumors. So a significant change or paradigm shift in how we try to remove these tumors. And then the other is the exoscope. I think we've used that's rather than a microscope to use a outside light source, and similar to what our kids would be playing to visualize everything. So here's a artist's illustration of the tubular retractor and the opening in the brain to access a deep-seated tumor. And I think when we look at that, there's several different types, as I mentioned, in navigation. And looking at these tubular retractors, whether it be circular, elliptical, and or others, what we do know is that it allows for displacement of the white matter in the brain, rather than having to sharply dissect that to get to where you need to get to. And this was a young child, a young girl that had a midbrain tumor, what we would call an anterior midbrain tumor. You could see it. And really, the question was, how do we access this? Do we go from the side there, from the front, the side, or the back? And this was just a group actually in Europe that I knew, and they asked my thoughts on how to approach it. And I said, I would go the longest distance from above with a tube and safely remove this. And you can see after surgery, this was a grade 1 astrocytoma, and you can see after the resection of the tumor, and they achieved a gross total resection, and she's not required any further treatment. And this was a grade 1 juvenile polycystic astrocytoma. Her deficit, she presented with a weakness and headache. It did get worse after surgery, but that recovered in several months' time. And she's required no other treatment. So I think, when we look at the adjuncts that are available to us today, whether it's the MRI, intraoperative navigation, it's like GPS in the car, but in the brain. We can look at the pathways here with diffusion tensor imaging. We've got intraoperative monitoring, ultrasounds that we can use to ensure that, are we going to be able to access the tumor, safely remove it? Intraoperative MRI to assess the extent of resection, fluorescence. These are dyes that some tumors will light up, and then remove the tumor. And then, this is another grade 1 tumor in the basal ganglia and the thalamus. And we did use the tube in a 14-year-old boy. He presented with some weakness, and then with the tube, let's see, don't even show it, that we were able to get a gross total resection grade 1 and not require any tumor. The other is, I discussed that minimally invasive. This is the keyhole. You can see, the ears up, the ear, the eyebrow, making an incision in the eyebrow, right in the hair itself so that you don't see it, a small opening, and you can see the opening in the skull, and then accessing the supratentorial region. This was first described over 20 years ago in Europe, and they described it, but clearly there's been significant advances in the technology as well as the way we use it. You can see how it's done. And this is a young girl that I treated several years ago. She had this suprasellar tumor, probably benign, that was being watched over 2 years. It was growing, and after with the growth, really recommended surgery. And this you can see the growth there. And this is the approach: small opening with just lifting up the brain, sliding under it to get to this. And then after surgery, really it turned out to be a dermoid, a benign tumor, and we achieved a gross total resection, and she's not required any treatment, and she's only had the small incision in her eyebrow and a very small opening. Really can't see it. And as I said, that in their original pediatric reports were in 2003, and now 20 years later, you can see that there's been 125 other reports that have published on this approach for both children and adults. Now, the question always comes up, and I mentioned it for medullo's as well as ependymomas: does the extent of resection matter? And really, what we do know that it does matter in children, whether it be a low-grade tumor or a high-grade tumor, and that children, it may not, the extent of resection may not have as important of a factor in adults. But looking at single studies as well as multi-studies, that what we do know is that children with malignant tumors, gliomas, astrocytomas, tend to do better than adults. And these are non-brainstem, non-diffuse pontine gliomas, but tumors elsewhere in the brain. And what we do know is that that the extent of resection of these tumors is significant to the overall survival. So that the the goal is to do as much of a resection as safely as possible before sending that child to radiation and chemotherapy. And I think, when we look at this, this was another study that looked at the national database of pediatric gliomas. And in their series, as well as in the database, in their SEER database, that looked at close to 3,000 low-grade tumors and 800 high-grade tumors. What they did find was that the tumor size was a prognostic factor, so smaller tumors did better than larger tumors. And again, for the low-grade tumors, that would make sense, because really it's the extent of resection. A smaller tumor is more easily, you're more able to achieve a gross total resection in a smaller tumor than a larger tumor. So the extent of resection does matter for both pediatric as well as high-grade gliomas in children. And then even in what we would consider now, what we had previously considered pediatric high-grade 4 glioblastomas, again, that's, there's different different name to these tumors now, but in this paper, what they found was that a radical or gross total resection of these high-grade malignant tumors in children, they tended to do better following the extent of resection, and along with chemotherapy and radiation, did better than just a biopsy. So even if we look at the brainstem tumors, and these were those exophytic tumors. These are tumors that start in the brainstem but go out. What they also found that the extent of resection does portend to a better outcome as long as one avoids the associated complications. And here, rather than gross total, they're saying a near total resection or a radical resection. And again, going back to ependymomas, that I had discussed earlier, what they found in this paper is that really the gross total resection for ependymomas in children is better than it is if a subtotal resection occurs. So, there's again the augmented reality that's available to us, the dyes that allow us to safely map the difference between tumor and normal brain to achieve resection. As we draw on time, I think I might just focus on the new technologies. I think there's laser ablation. That's where inserting a laser fiber and thermally ablating a tumor, whether it be a low-grade tumor or a high-grade tumor. There's been it was originally for hypothalamic hamartomas and epilepsy, but now even low-grade tumors. Many centers are starting to use it for low-grade tumors, and this was the original therapy using it for this hypothalamic hamartoma to insert the laser fiber under MRI guidance and thermal regulation, controlling the temperature to thermally or really burn the tumor. And you can see 6 months later that's gone. And you can see these tumors. These are a variant of tumors of subependymal giant cell, both with the open or the laser. And you can see the results of the open resection versus the laser, and that really that the laser was equivalent to the open surgery with much less risks associated. And in terms of their slightly higher risk of recurrence, this is a low-grade tumor. That you can see the laser fiber is in there, and then you can see here's the tumor that was thermally ablated, and then the postoperative scan. Tend to do a biopsy and then do the thermal ablation. And there's a learning curve. This is from the adult literature in Miami that says that their operative time went down when they looked at it with their initial experience with 250. The latter series, their operative time went down, their complication rate went down, and they reported a complication rate of close to 5% versus 8% earlier, and that the risk, although the readmission rate, again, this is almost an overnight stay or a hot 2-day stay to do these procedures, and then finally, focused ultrasound. Really, this is new. There are some centers that have access to this, and there are two types of what one can do with focused ultrasound for both children and adults. You can treat low-grade tumors with this focused ultrasound, very, very similar to the laser ablation, but using the focused ultrasound machine, one can essentially does an ablation of that low-grade tumor, and you can see this here. Or the other thing for higher grade tumors is that using HIFU, or it's really two different types. It's high intensity versus low intensity. Using HIFU, one can disrupt the blood-brain barrier and then try to treat, which opens up the blood vessels to chemotherapy agents for malignant tumors such as DIPG. And you can see here, what this technology, whether it's a blood-brain opening, one can disrupt the tumor and then do a biopsy, a liquid biopsy from the CSF or from the blood to obtain a tissue diagnosis, immunomodulation, or radiosensitizing that tumor to traditional therapies. And I think, is this the promise? Is this the answer for diffuse pontine gliomas? I don't know. There's only several centers that are doing the trial for this. And I think, the results will need to be borne out, for these diffuse pontine gliomas. And I think, when we look at this, this focused ultrasound, whether it's low intensity to treat the low-grade tumors and or high-grade tumors versus the high intensity to be able to disrupt the blood-brain barrier. And here's this is a recent review paper that looked at the treatment with the ultrasound, whether it be a low-grade tumor, hypothalamic hamartoma, and or in animals or DIPG, and you can see all the studies, all the papers that are on it. So I think, I think with the last 10 minutes to leave some time for questions, I think, I've discussed, the new classification, looked at the functional outcome based upon the extent of resection for these, and then using the minimally invasive techniques, whether it be tubular retractors, the keyhole craniotomy, the laser ablation, and or focused ultrasound to treat both the malignant and the low-grade tumors in children. All right, I think that should leave us about 10 minutes for questions. If you want to scan, please provide your feedback. Uh, Alex, thank you so much for allowing me to speak today.
Yeah, so we will start with questions that came from registration, and then we'll get to ones that were asked during the presentation. Can you talk a little bit about the transition from pediatric to adult care and surveillance post-surgery?
I want to say most pediatric teams, whether it be the neuro-oncologist, the oncologist, neurosurgeon, neurologist, I think, most pediatric teams are a little more family-centric than adult centers, which may not be as sensitive to the entire family, not just the child, but to the parents as well as the siblings. But again, it's really just I think the most unbiased, being a pediatric neurosurgeon. I think pediatric centers tend to be more, besides being family centric, I think we tend to be a little more comprehensive for the entire family unit versus the adult centers, which tend to focus more on the adult. I don't, is the care any different? No, I don't think the care is any different. I just don't think it's um, as centered around the family unit once transitioned to adults.
Can laser ablation and focused ultrasound be used on inoperable optic nerve gliomas?
Yes and no. Yeah, I think there's, depending upon the shape of that optic pathway tumor and the size, there are some groups that are considering, will consider focused ultrasound. Again, it's very new. I suspect that, we will be able to use it for certain optic pathway tumors. I think for the laser, I know we've used it in some cases already for optic pathway tumors. So yes, on the laser, it can be used, but it's very specific to the size and the location. Again, what we have to worry about is the optic nerves and making sure those aren't damaged, the blood vessels, the carotid artery, other vessels, and the pituitary gland, because you're using heat energy to ablate them or to destroy the tumor cells. So really need to ensure that we protect those structures when it's treated. So is it mainstream? No. Can it be used? Yes, for very specific subtypes.
And how rare is it to have a large tumor that's both in the infratentorial and supratentorial?
In children, it's less common, but you can see it. Adults are more likely to have tumors that involve both the infratentorial and the supratentorial. You could have meningiomas or other tumors that go both ways. In children, really, you can have a high-grade tumor that's infiltrated that starts up in the thalamus and works its way down to the pons, or vice versa. You can have also some low-grade tumors that go start in the thalamus and go into the midbrain. But they tend to be the larger tumors and less common. They tend to stick to one place or the other, supratentorial or infratentorial.
Can you talk a little bit about your understanding of neuroplasticity and the need for rehab post-craniotomy, irrespective of how well one appears to have done in surgery? Or
Yeah, I think that's a great question. I think, the wonderful thing about children is they tend to have a little more neuroplasticity than you or I, as adults. And that, if they incur a deficit, they're more likely to recover if provided intense therapy, and stuff, physical therapy and occupational therapy. Their brain tends to rewire as well as develop, has the ability to accommodate a deficit that might be incurred from surgery. I can tell you, speaking from, the other hat that I wear, epilepsy, where we may disconnect or cut out half the brain, you would think that these children would wake up paralyzed completely. But it's remarkable that the other side takes over and allows them to almost be, almost fully functional. They have a little deficit, don't get me wrong, but rather than being completely paralyzed on one side, the other side of the brain picks up and is able to accommodate for them. Again, that's neuroplasticity with intense therapy as well.
And can you talk a little bit about the difference between gamma knife and radiation therapy?
You know, so gamma knife is radiation therapy. It's just stereotactic radiation therapy. It's really what it's doing is giving radiation in a highly focused beam to the point, the target, in a higher dose. So it's essentially the same. Radiation therapy, you give small doses daily or 5 days a week, in very small doses to the target and to the brain. Gamma knife, you come in, it's a 1 day procedure with a head frame stereotactic to guide the radiation source to the target, all focused on that target in much more larger intensity. But that's the same.
And one of the questions was someone's curious about the latest information on proactive treatments post brain surgery.
I'm sorry, proactive treatments post, I think one should be again, my recommendation post brain surgery is after the child's recovered and, the treatment team clears them to start, whether it's to start therapy, relive their normal life. I encourage trying to get them back to a normal schedule as soon as possible and being active, honestly, participate in sports, I try to avoid contact sports given the brain operation, but, riding a bike, walking, exercising, trying and, going back to school, the sooner the better. I think, it allows the children to be, feel like they're more back to normal. And that would allow for, I think it personally speeds up the recovery process.
And what are some surgical options for a recurring tumor after gross total resection?
So after recurrence, it really depends, the tumor histology, what type of tumor it was, and so it depends on the histology, the location. Even after a gross total resection, if some tumor comes back immediately, that's very different than a tumor that may come back after several months or several years' time, because you may want to consider a second operation and or adjuvant treatment, whether it's now you may want to even now consider chemotherapy or radiation, even if histologically it was a low-grade tumor.
So that looks about like all the questions that we have time for.
That's awesome.
So on behalf of the Pediatric Brain Tumor Foundation and on behalf of myself, I really want to thank Dr. Jallo for taking the time today. I know he's got a super busy schedule. And I also want to thank you, our attendees, for your participation and thoughtful questions. The Pediatric Brain Tumor Foundation is here to help no matter where you are in your journey, whether you're just diagnosed or in survivorship. So please reach out to us for support. We'll be sending a link to the recording of the webinar as well as the slides from today's presentation soon. So look out for that. And again, thank you, Dr. Jallo. We really appreciate it. And thank you to everyone who attended. Have a good rest of your day.
No, Alex, thank you, and thank everyone who participated today. And I really want to thank the Pediatric Brain Tumor Foundation. I mean, I think you are critical for the children and for their families to help guide them or point them in directions, because it is, you know, it's uncharted territories for a lot of these families when they get a new diagnosis. So I thank you all for being strong advocates for the family. Have a great afternoon.